This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of post-op care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're looking at major incident management, and we're looking at 3 different episodes we've had on the podcast with Keir Alec and Phil Cowburn. So first up is Reflections on Major Incident Management with Keir and Alec, and they really walk us through some of the lessons learned from their anecdotal experience within major incidents, but also some of the significant major incident inquiries such as Manchester bombings and others. We also look at how we use both the TST, so the 10 Second Triage, and the Major Incident Triage Tool to really enhance care at the scene. We also examine the concept of this P1+, so the patients that are actively dying on scene. Then Phil Cowburn walks us through how they have tested and tried and formulated the TST and how that interacts with the MITT, and then some of the reflections on how it's been put to practice in real life, and also some of the interdisciplinary agency working which has taken place. And then we finish with Alec and Keir again on part 2 of Reflections on Major Incident Management, and we look at what good clinical leadership looks like on scene, and also the reflections on where the TST and the MITT actually fit within the major incident triage protocols, and the contemporary use of the TST within day-to-day practice, such as road traffic collisions or otherwise, where there is multiple patients, to get used to using the tools. There's some fantastic pearls of wisdom in these conversations. They really are a distillation of wider conversations we've had on the podcast. I really do hope you take some valuable insights from their received wisdom. And it's always fantastic just showcasing the lived experience combined with the empirical research and the application of that to real world practice. Okay, I do hope you enjoy, and we'll see you again on Monday.
We've had high exposure to kind of real world experiences that we've learned from, and that's kind of shaped the way that we practice. And clearly, in kind of from November 2016 through to 2017. We saw a large number of major incidents and significant incidents, including the Croydon tram crash, London Bridge, Westminster Bridge, Grenfell. I suppose for me, my reflections, the incidents I was involved in, both from EOC and operationally, were London Bridge, Croydon, Fishmongers Hall, as well as some other significant incidents. But I think if I was going to reflect on them, it's my training prior to that point had really been around MIMS. And I think my experiences and the experiences of others and working in London is, I think, a lot more critically now about major incidents and my approach to them. However, it's still the same cohort of patients that we see day in, day out, but just on a larger scale, potentially in fairly unique and challenging environments. And I suppose my take-home points that I'll probably will talk a bit about later is that the importance of that first 20 minutes, your performance under extreme stress and fear as well, the importance of clinical leadership by senior clinicians, the importance of walking the scene, and also really about not all P1 patients are the same, and that some P1 patients are sicker than the others, and some are actively dying. I think I'll talk later about really perhaps that kind of approach to that patient group and how we identify them. And finally, we have to understand the disease process of the patients that we're seeing, and not just because it's the major incident change the way we care for them. And we should do really what we do day in, day out for them. Certainly in London, around penetrating trauma, we promote really short on scene times to move into hospital, and we probably should have to try and remember that.
I think it's funny, we talk about major incidents and actually, like, it's just a term, it's just this defined term, and there's been a lot of significant incidents in London and around the country as well that never get they never quite tip that threshold into being a major incident, but can be really, really challenging. I think when we talk about this stuff, they kind of sometimes get overlooked. And I think what's good now is that, particularly in London, I think we're really good at ramping up early. And I know some of the stuff that seems to be more commonplace in practice now, things like people giving ethane reports to a like an RTC, relatively simple RTC would still give an ethane report, and getting used to that reporting mechanism. And just, I think everyone's now understands the concept of it's easier to ramp up early and scale down than, to be, I think perhaps when I started, maybe apprehensive about declaring a significant incident or a major incident. It seems like can feel like quite a big thing, but actually it's just a term that will, get you a then defined response. I think that's the really, really important thing when we're talking about major incidents. They don't, I think they're often associated with, a really, really bad day at work, and it's not obviously to detract away from the fact that a lot of major incidents inherently by their nature, involve sadly lots of people being horribly injured or becoming really unwell or even dying. But there's been other major incidents that the ambulance service has been part of that have been challenging but not been the same. So there's the Stratford Olympic pool incident a little while ago where 200 people were evacuated and as a result of a chlorine gas leak, and lots of people had shortness of breath, and that's challenging to respond to, it's challenging to manage, but at the same time, these are good opportunities to put all this teamwork stuff into action.
We look at things like London Bridge, Manchester Arena, and some of the other incidents, and many lessons have been, or recommendations probably were already put into place. But obviously, Manchester has its inquest is probably the most recent. We've also had Grenfell as well. I think one of the kind of most overarching themes that came out of having read the emergent kind of part 2 of the inquest was really that kind of the issues around Jesser and kind of the breakdown in kind of that situational awareness. I think it's probably worth remembering that the huge challenges that those people, that the kind of our colleagues up in Manchester will have had to have dealt with arriving at that incident. And probably, in terms of it being an attack using an explosive device, of all the incidents that we've seen to date, it's probably been the more sophisticated of them. And that things like, London Bridge, Westminster, and Finsbury Park were all quite unsophisticated, using knives, using vehicles. I think my kind of takings around the initial kind of care, I think that's what you're asking, I think, Owen, on that, is that, and it's not just from Manchester, but probably through multiple incidents, including things like the Derek Bird shootings, it's about the access to patients in potentially in situations that might potentially have safety implications. And for me, I think one of the big reflections I took from my experiences around the need to actively, the importance of reducing preventable death and accessing a certain cohort of patients that we know are critically ill and need rapid access to them and intervention to keep them alive, followed on by evacuating them quickly and progressing them through the scene to definitive care. So with that comes in everything else, and a structure in place that needs to be kind of followed. But I suppose, like, my takings really from certainly looking at Manchester is absolutely that kind of delay to getting to some patients, and really that kind of lack of situational awareness, or the kind of loss of situational awareness, and that only three clinicians ever found themselves treating patients in the city room, 1 APP and 2 heart paramedics. But it also showed the role of senior clinicians, and an APP, I think he was in there for 40 minutes, I think, by himself. And I think Alec wants to talk more broadly about that later. And also, again, like many incidents, the importance of bystanders. But it also showed reoccurring themes around extrication and moving patients, and perhaps some kind of that perhaps didn't go as well, and that the kind of how patients were moved. And I suppose for me as well, it's around the time that patients spent in the casualty clearing station, and there were some kind of discussions, I think, both in the Kerslake report and the recent Manchester inquiry report, around patients being stabilised in the casualty clearing station. And I think it's all around probably about the importance of flow and about moving people through the scene as quickly as possible to hospital. And I think what in the Kerslake report, he said that, that having patients for a period of time in the casualty clearing station, it allowed the hospitals to prepare operating rooms. But at the same time, we know from patients with penetrating trauma that the longer they spend on scene, the chances are they may have a higher mortality. So it kind of, there's a conflict there between what published evidence really, and I think the important thing is the patient flow.
Alec, from your perspective.
So with regards to Manchester, I think the first thing that every time I read the report or I hear someone talking about the report, the first thing that always comes to my mind, like, I really really sort of, feel a lot of empathy for the responders who attended the Manchester bombing. And I think it's hard, even having been to, again, it's this term, major incidents, and they're so varied. You look at the last 10 years and the things that have happened, and you've got things as Keir's already sort of alluded to, like Grenfell and these terrorist attacks and all these other, and lots and lots of really challenging, significant incidents as well. But Manchester's quite unique, and I think the reason that the Manchester bombing is quite unique in the UK, and even further afield actually, is that it was children that were deliberately targeted. And I think it's really hard to imagine turning up to something like that and there being so many young people with such serious, horrendous injuries. And I think the reason it's significant is the moral injury from that is always going to be really high. It's not something we've seen in London where children have been deliberately targeted. I know, obviously, there was the Wimbledon incident a couple of weeks ago, which very much sounds like, I know it's all still early days yet, but this is still different again. But I think the real kind of injustice would be for all of us who work in the emergency services. The real injustice would be to not talk about this stuff and not learn the lessons and not look at this. So it's good. I think it's good to talk. It's really important that we talk about it. And as Keir said, from my experience, I think from listening to lots of people like Keir talk about his experiences at London Bridge and the other APPs and the HEMS teams that have been to these big incidents, the one thing that's really clear is that the first 20 minutes of any incident like this is critical, not just to dictate the flow, as Keir was talking about, but also when it comes to making those decisions to stop preventable death. And that's the one thing from Manchester that really came out, is that this there's this concept of decision inertia, wanting to wait for more information that may not even come before being able to make a decision. And I think, again, from my experience talking to other people, there's that need for rapid decision making. And in an ideal world, it's commanders are going to be making that jointly and together, but it's also, I think, really important to accept that that's not always possible. And often, if you can see something that needs doing, and you're going to make that dynamic risk assessment yourself, then there's a job to do, and we need to crack on. It's also unlikely that any other service is ever going to say that it's safe. I can't imagine a situation when the fire service, the police are going to turn up and be like, "Yeah, it's safe. You guys can go on in." It's just, I think these are they're sort of almost false false narratives that we want to have to reassure ourselves. But the reality is, the buck's got to stop somewhere, and I think a lot of the time that's us. But it has to be dynamic. And that's not to say that people should go rushing into situations, but there's the concept of the what if trap. And at Manchester, there was this concern around a second device, but there was no credible evidence of it at all. So I think it leads to needing to rely on gut instincts, but also to mitigate the what ifs. And there's tools in place that commanders use, like Eric PD and this sort of stuff.
I think with my experience, certainly the one I talk to most is about London Bridge, really. And around being dispatched as the initial kind of response to what was a single patient in traumatic cardiac arrest on the bridge. And then very quickly finding myself in what at the time was really an evolving, still an ongoing terrorist attack. And finding yourself in a very unique situation so early that you hadn't prepared for, because your mindset has very much been on one patient, and suddenly finding yourself in feeling considerable fear and threat for your safety and your life as well. I think certainly in the first 20 minutes of that job, with ongoing shooting by the police, and not really being aware of who was actually shooting at the time. But then I think it's, as working in London and working as APPs, you become quite used to working in complex and challenging environments that can often be fast changing and often aren't necessarily always what you think they're going to be when you arrive. And I think kind of talking about safety, I can really remember, we know a lot of incidents are over quite quickly. We know London Bridge was over within 8 minutes. I think Westminster was over very quickly. And when we look at a lot of incidents around the world, generally they have a short time where there's an active threat. And we know, like Manchester, when they looked at it, and they actually, if you turned to zoning by 2250, it was actually a cold zone. And I think for me, kind of reading the scene, engaging situational awareness, and I think I was probably I can look at London Bridge, and I think I can kind of, like, reflecting on it afterwards, subconsciously using people as an indicator for active threat. And I can remember being there and being told constantly by the police that, there's an active shooter coming down from the South Bank. But actually, that was people calling in 999 calls saying they could hear shooting, but they were hearing shooting in London Bridge. Or they were finding IEDs, or there's a hostage situation, or there was an IED in the van. And I think the fog of war, like you say, Owen, you're never going to truly, truly know what the genuine kind of risk to safety is, as opposed to what might be perceived, because the fog of war, that's going to happen. There's so much information. It's so chaotic. And it's interesting. I think, like, we probably look at a lot of those incidents around what happened in 2017, and we talk about safety, which is critical. And, it's really important. We have a duty of care to our staff, and we have a duty of care to patients. But how many members of staff were actually injured? And we talk about, kind of threats from an active shooter or from a secondary device. But really, probably what do we think about is that potentially some of probably what the current evidence shows is that, the real probable some of the safety risks where they lie are more conventional scene hazards. So things like contaminating dust, kind of collapsing structures, secondary contamination at chemical incidents. And probably for me, the really big one is the impact of mental health on people post these incidents. And that's probably something that we don't talk about as often as we probably should be. But yeah, that's probably my experience and take on it.
I think the sharing of information is key. And by that, I don't just mean commanders, responders on scene. I mean, the call takers extrapolating all the right information. I think arriving on scene, doing early windscreen reports to relay that information back, and then sharing information on scene as well, so that people can make dynamic decision makings. I think being mindful of decision inertia and aiming to make decisions dynamically and rapidly, being aware of the major incident structure, but also the requirement to be pragmatic. But yeah, looking forward to chatting about the rest.
And to yourself, Keir.
So I think kind of what I've really taken from this conversation is about the importance of, from very first off in the control room to those first arriving and all the way through, is about how we gauge situational awareness and get information at each different point to help us critically think about how we're going to manage the incident and those patients. The other is really around reducing early preventable death and identifying those that are actively dying on scene, or the P1 plus patients, because not all P1 patients are the same. Some are far sicker than others. And finally then is around patient flow. And that when we identify those really sick patients, we need to be thinking about how we progress them through scene as quickly as possible, and about moving them as quickly as we, not even necessarily going through a casualty clearing station, because my belief is really that the casualty clearing station isn't somewhere necessarily we're going to be able to stabilize the most sickest patients. And these patients really should be being moved off scene as quickly as possible to definitive care. Certainly in somewhere like London, where we have 4 major trauma centres. And I think there's probably a whole discussion about how you do that in the counties or places that can't do that necessarily and get patients to those places as quickly as possible.
There was a number of us working under a task and finish working group from NHS England, looking at revising what was our current triage tools, which at that stage was the NASMED NARU SIV and also the triage sort. And we were looking to take evidence-based practice forward to try and revise those. Myself and Claire Park had been working for quite a bit of time on considering quicker triage tools that could be used in the hands of lay responders as well as clinicians. And we were also very concerned around the cognitive load that you will undergo in an incident like this. The bandwidth of responders will be markedly stretched during something, the sight, the sound, the smell, and everything that is going on around them on the worst day of their life. Are they going to be able to do the things that when you're sat in a classroom may make absolute sense? So we were working on that, and there was a great group of academics and pre-hospital practitioners involved in that. And we said, but hang on, what we want is something that is very quick and very easy, and just focuses on those immediate life-saving interventions that we know will make a difference in that very early stage. And the research that Claire is doing at the moment, and evidence that we've had from a number of incidents, we know that the things that will kill you in that early stage are loss of airway and severe bleeding. And if we could just have something that purely focused on those. So Claire and I had been working, we both work for different police forces, and we'd been looking at options for, delivering life-saving interventions and prioritising patients in more tactical situations. So we'd got some models on that. And when we came to the first iteration of what then turned into the Major Incident Triage Tool, working with Jamie Vassallo and his stuff he'd done with MPTT 24, we devised this tool and we put it through a fairly extensive field test. And this was a series of mock major incidents, and we had a range of paramedic practitioners, right from students through newly qualified to experienced, through heart and critical care practitioners, and we put them into these environments and got them to use these tools. And we were looking at both qualitative data, how accurate were they, how long did it take, also, more quantitative data looking at that, but also qualitative stuff like how did it feel, how easy was it to use, and taking feedback. So when we tested these tools, we just saw everything that we had feared. People cannot count pulses, respiratory rates, do the arithmetic. No one's wearing a watch anymore because we're bare below the elbows, and just the burden of the physiological criteria just exceed the bandwidth that any responder has at that time. And this was just in a simulated exercise, so it wasn't even as stark as the real thing. So we really went back to try and look at options for triage tools that didn't use any physiological variables to try and take out that burden on people, but to really focus on the life-saving interventions. I'd been working on a tool with my police officers which was very straightforward, which was just kind of walking, talking, not breathing. And Claire had been working on one with Metropolitan Police, which also highlighted penetrating torso injury, which we know can be related to incompressible hemorrhage that cannot be dealt with, and to prioritise those patients. So we did a little bit of a smash the two tools together, and we came up with the tool that is now known as 10 Second Triage Tool, and it's designed to be very quick and dirty. It's not designed to be the most sensitive, the most specific. It is just designed to be put in the hands of as many responders as possible to get those life-saving interventions done, have a rough idea on the prioritization of those patients. And this very much aligned with the ongoing, at the time, Manchester Arena inquiry, looking at the tragedy from the City Room, and realizing that when you have a large number of patients and just a very few responders at that initial stage, you want someone very quickly to go round, save a few lives, and then get an idea on the enormity of what is going on. So that's kind of how we came up with the idea of what turned into 10 Second Triage. There was another bit that we really considered, and this has become more and more important to me as I've discussed this with a lot of responders that have been at major incidents such as Manchester, Borough Market, London Bridge, and that is that on the previous tools, you just opened the airway, and if there was no breathing, you counted them as dead. Now, in those early stages, you don't know the enormity of the scene. There may only be 5 or 10 people there. So consigning somebody that doesn't appear to be breathing as dead, when we know that the survival rates from traumatic cardiac arrest, if really aggressively managed, are certainly significant. And of course, those responders have to make that decision in a split second. They then have to live with that decision, and they have to go through the public inquiry where that decision will be scrutinised in front of friends, family, and coroner cases. So we were keen to put in a new category of not breathing, which is saying, we're not saying you're dead yet. You may well turn out to be dead. What we want to do is just put you in a position of safety, roll you in the recovery position, if resources allow and there's people wanting to deliver CPR, we won't get in the way of that. And that will allow us to move through the entire casualty chain and then come back to them once the dust has settled a bit, when you have that cognitive ability to properly rationalize that decision. And what's been very moving is speaking to a couple of responders from big incidents that say, I wish I had that, because I was really struggling to make that decision in that split second. Is this patient dead or not? Are they viable? So when we created this tool, and I still like the fact that I referred to it as quick and dirty, and you totally get that. That is the title I wanted to call it, but some very senior figures within NHS England just frowned upon that. But I still think if you explain it as that to responders, they know exactly what you mean. So what has been, I think, quite unique in the development of both the 10-second triage tool and the MITT is that we have field tested them extensively with a wide range of responders, looking at quantitative stuff, the time, the figures, how quickly can it be done? Is it done accurately? But also the qualitative stuff. How did it feel? Was it easy for you to use? As the training rollout has gone out, I'm picking feedback up from different areas around the country, and certainly I've seen it used in a couple of reasonable size incidents locally to me. We will never know until we have a true big incident as to how well this works. But what we designed for that kind of massive surge, that city room shock and awe when you walk in there as two responders and there's 300 injured people, what we designed for that, we found, was actually very quick and intuitive for that RTC with 5 patients, where you turn up as the solo responder or just a pair of you and you go, we're a little bit outnumbered here, but this is so quick and agile that it can be used on those. So we've had one incident where there was quite a bit of gangland violence and a lot of people injured by bladed weapons, and it was a very hectic and confused scene. We had police, public order police and firearms police and ambulance staff in the middle of the scene, and 10-second triage proved very, very effective at just getting an idea on those patients. And one of the bits we were always questioned on is why isn't catastrophic hemorrhage first? Why is walking first? Well, it's in there mainly because you want to thin down the numbers very quickly. People with true catastrophic hemorrhage seldom walk, or not very far. And there is the common sense caveat in the tool which says if they look like they are bleeding, ask them to sit down and triage them. So we got some good feedback from that, but probably the most moving example I had was a multi-vehicle RTC that was probably, I'm trying to think how many vehicles, 5 or 6 vehicles. One vehicle had crossed the central reservation and gone head on into a number of others. And I think there was probably 15 or 16 patients. About 100 meters away from this incident was a police public order van with 6 public order people on there, 2 medics. They arrived on scene and they had triaged everyone before the first ambulance resource arrived on scene. And it was just incredible. So the poor ambulance officer who was first on scene came up and said, right, I need to get a handle on this. We need to start triaging. And the police sergeant said, don't worry, we've done them all. You've got X number of P1s, these P2s and these P3s. And it was actually quite funny to see what happened next, because it was like, oh, we've now moved much further through than you would anticipate, but we knew that all the life-saving interventions had been done. So it really does give you an ability to get a handle on what is going on very quickly. And the more it is being used, the more we will get feedback on it. Yes, so I think if we embrace the idea that we will use TST on any incident where we are feeling outnumbered, so that may be something truly massive, Manchester, London Bridge, something like that, or it may be just something like that, those 2 cars head on somewhere in a very remote and rural location. Once you've used 10-second triage, you have prioritize your patients into your P1s, 2s, 3s, and silver, not breathing. I think the next big decision that comes is this of such a scale that I now need to go into the major incident triage tool, or is this of a scale that is manageable that I can just run as business as usual? Are more resources with me now? And I think that really is an operational command decision, usually with a senior clinician involved, whichever is the most senior clinician you have on scene, to decide, do we need to instigate MITT, or can we just run this as business as usual? Because ideally, we want to give the patients the standard care they would have if they were the only patient. So if you can manage it as business as usual, do that. So I think that's the kind of command decision from the individual clinician's decision making. I think the two bits for me are, once you've got 10-second triage done, you will have some P1 patients, and you need to find the true time critical ones within that P1 patient cohort and get them moving off to definitive care. Rather than using all of your staff to fill up functional roles, you need to start thinking about the patient's need. So I tend to turn, you need to go around and find the P1iest of the P1s in there and get them moving off to hospital. And that really is a clinician's decision. That isn't necessarily for our emergency service colleagues to do, because we have done the bit that has highlighted them as P1. So that would be my first priority. My next priority would be to take a clinician and go around those silvers and decide whether they are truly dead, and you can take your time and do formal verification of death, and then that will be dignified. It will be done in a much more calculated and timely way that can be justifiable both for yourself as a responder and come whatever legal scrutiny happens. Or within that silver cohort, if there is perhaps just one of those and a number of not too badly injured patients, maybe it would be appropriate to deliver the ultimate level of care we would do anyway. So a lot of that, I think, really comes down to, you can only make that decision once you know the entire scope and enormity of the scene that you are dealing with. So until 10-second triage is done and completed, you don't want to be making those decisions. But the two key bits are find the P1ist of the P1s, reassess the silvers, and that's focusing on the patient needs. What about chest seals? Should we be putting chest seals on, which I keep getting asked? Well, the answer is they take time, and we know chest seals stick to two things principally, gloves and themselves, and they don't stick to the patient very well. And the chest seal is not a life-saving intervention. Recognize the penetrating torso injury. If they've got an open pneumothorax, get somebody to put a hand on it, move on, finish triaging, then come back and do that. So if you go onto the NARU Education website, there's lots of bits about the how to teach it, some videos, and the frequently asked questions, which will really help if you want to get an in-depth bit. We've had a couple of scientific articles come out regarding the philosophy of why we started it. We've got the work coming out from the Behavioural Insights team looking at the qualitative feedback on it. And yeah, there'll be more publications coming out very soon around the timings and the benefit in time to life-saving intervention.
Bill, that's fantastic. And we'll put those links in the show notes, actually, because it'd be great, like you said, just that people can do a deep dive and just look at the spectrum of information which is out there. So thank you for that. It just leaves me to say thank you, Phil, for the last 45 minutes. It was fantastic just to pick your brain and have just your perspective on the progression and fruition of this tool, which has been really, like you said, the adoption's been fantastic, but the battle testing as well and the application. So but thank you so much for your for the last 45 minutes.
No, thank you, Aaron. And I think it's just a massive thanks from me to the team that helped create this. This was myself, Claire Park, Jamie Vassallo, Sean Harris, Dave Ball, Jason Smith, we all just sat down and came to it from slightly different perspectives, and it came together really well. And I'm really grateful to NHS England for supporting it. It's been 2 years of hard work before we got to the point of being ready to roll it out, and it's still being rolled out now, and it's fantastic. But I think it will save lives.
Yeah, so I suppose from experience, we know that one incident isn't the same, and that goes with the same with kind of the presentations of each patient at each different incident. And so we get this kind of multitude of patients, certainly say from Grenfell, there were patients with smoke inhalation. Then you might have one incident like Westminster Bridge where you have lots of patients with blunt force trauma, and then somewhere like London Bridge where you have patients with penetrating trauma. And so I suppose, when you're looking at triage tools, triage is going to be kind of one of the first kind of clinical priorities in a kind of multi-patient incident. And it's really happening before kind of the real, obviously, life-saving interventions are being undertaken. But in terms of kind of any more extensive care, that triage is happening before that process. And the idea really behind triage is to identify those patients who are the sickest and require life-saving interventions to keep them alive. I think what's kind of why we've had a recent change in triage is that kind of looking at what we've been using perhaps in the past hasn't been particularly accurate in identifying patients with requiring life-saving interventions. But also perhaps is that, people, as we discussed last time, that people might not necessarily be using them to how they should be. But it's going to be difficult to kind of shoehorn all different clinical presentations perhaps into one tool without it becoming really complex. And the more complexity you add, people are simply not going to use it. So it needs to be simple. It needs to identify patients that require the right care at the right time. And it has to have an acceptable under and over triage rate. And so, yeah, simplicity is probably going to be the key. I think that's probably my take on it. Alec, do you?
I think triage, exactly as you said, it's a pretty blunt tool. I'm not entirely convinced that it does need to change. I know we're going to talk about it in a second, but 10 Second Triage and MITT, I think it's a really good piece of work that's come about after quite a long time. It's changed the practice that's been the standard for a while, and there was absolutely a need for change. But I think as inherently in its nature as a blunt tool, I think it's easy to overcomplicate what triage is, and it's exactly that. It's a very fast snapshot of exactly what you're dealing with and these different modality of injuries. I think it's the simplicity. Triage will capture all of that. I think if anything, talking about triage tools changing, maybe this is a good time to start talking about the role of enhanced care teams or APPs or CCPs at these types of incidents. And I think we touched on it before, but often in the first 20 minutes of an incident, these things can almost be like an oil tanker. Once they're set on their trajectory, it's very difficult to slow them down or change their direction. But having clinicians with extra skills, perhaps extra knowledge, who are more used to working under stress, they're able to see the bigger picture and try to find those patients. I know, Keir, you've talked about before the P1+, but able to find certain types of patients who will benefit from certain interventions. And that could be a case that, I know looking back over some previous incidents, trying to think of some good examples now, but I'm sure at London Bridge, I can certainly think at Westminster Bridge, there were already some people on scene doing some really, really good things. And it was a case of, I think for me at least anyway, I saw my role as supporting and empowering really good practice that was already taking place, and perhaps seeing things that needed to be done. I wasn't an APP at Westminster Bridge. I was a team leader, but turning up, it was very clear that there weren't many ambulances, but being a major incident, lots were going to be arriving. And again, it was from training that I knew that actually the bronze parking role was probably the most immediate role that would need to be undertaken. So whilst people were going over the bridge, triaging people, finding an appropriate place to have ambulances park up, and keep crews together, give their keys or touch base with one of the ROs, so that it was all in an organised manner, so that lots of people didn't park up everywhere. Little things like that, but there's so much variability, and it's all so much case dependent that I think it's kind of why triage exactly as you said needs to be simplified, so that it can capture all of these different types of incidents, because they're all so different. I told you I'd say exactly what you said, but in a much more waffly way.
Owen, what was your experiences? Obviously, we're some time now post 7/7 about the kind of triage and its use back then to perhaps what it is now.
Yeah, so I believe that actually we were probably doing what we're doing now covertly rather than overtly. So although physiological markers were playing a part in the explicit triage, actually it wasn't happening that way in practice. I think we were looking at subtle or indeed explicit markers of injury, so unconscious, extensive thorax injuries, and indeed just the mechanism of injury, irrespective of the physiological markers. In 7/7 I was never taking respiratory rate or indeed pulse rates. They were either conscious or unconscious with blast injuries, with profound burn injuries, and they were easily identifiable as priority 1 patients. There was I suppose in essence both at King's Cross and indeed Aldgate, there wasn't this explicit, let's take the respiratory rate and pulse rate. It was they made themselves overtly clear as priority 1 patients. So and talking to other people from different major incidents, it seems to be that was the case from the Croydon tram crash. There, going through, there wasn't these physiological markers which were being monitored. They were explicitly priority 1 patients from marker injury, and so I think what it's done is it's probably reflected a true indication of what really needed to what does happen at scene, what needs to happen at scene. And one of the big things I took really from being part of the advanced paramedic scheme as well as London HEMS was just this adage of triaging together, because actually it can change, it can be dynamic, but actually it's really good just to test your decision making in the moment and have, in the Croydon tram crash, a couple of our colleagues just went around and triaged together and dynamically bounced right priority 1, priority 2, priority 3, priority 2. And actually it's really good just to be able to bounce that out off another colleague and then move sequentially quickly through a carriage or quickly through a scene. And I think let's come on to the TST and the MITT tool now, because what it is, the 10 second triage tool is clearly got it's meant to be done rapidly and make rapid decisions. And then the major incident triage tool may be in a more extended version at some kind of holding or casualty clearing center. But if I could get you guys to speak to the TST and the MITT, because in my perspective, it's what always should have been happening. It's always what was happening. We've just made it explicitly clear that this is the preference now, and we've got empirical evidence to back it. Is that both of your experience? Because Keir, you've pressure tested it in simulation quite recently. How did you find the interplay?
I thought it was good. I think having kind of read around it, listened to your podcast with Claire, and I suppose having had experience of triaging patients in multi-patient incidents, it feels a lot more in tune with probably what happens, certainly TST, around actually what happens in the real world. and probably more likely to be used. And I think it's got a lot of benefits in terms of certainly early on it can be used by any member of the emergency services. It's taken the kind of physiological elements out of it. If we were going to look at enhanced care, just going on to that kind of just before I kind of round up, is that you do need some nuanced decision making about patients. And that's where your kind of critical care teams, your critical care paramedics can come into play. Because not all P1 patients are the same. And some patients that are maybe P2 are going to have more complex needs than other P2s. And that might be around things like analgesia or limb reduction. But there is a risk to the P1 plus, and there is a risk to that kind of decision making by senior clinicians, is that the risk there is that those clinicians need to be experienced, and they need to be experienced with the cohort of patients they're managing. And there's very little kind of really published around this. Some of the Israeli case series or publications that they've reported on have looked at anatomical triage by doctors during explosions within Israel. But what they've said is that to be effective, it needed to be by doctors that were used to dealing with blast injury. And there's a case from Japan. It's one of the worst attacks using a bladed weapon. It happened a few years ago at a facility for disabled people, in which I think it was about 19 people were killed and above 40 injured. A lot of patients, because the triage tool that they used didn't necessarily match the patients that they were dealing with, they ended up over triaging a huge number of patients. And when they actually looked later on about how many of those patients really needed life-saving interventions, it was far fewer than what were identified. And perhaps, if you're making that kind of nuanced decision making, you do need to know the patient group, because I imagine in Japan, in the patients they were managing, that cohort of patient they weren't maybe necessarily used to seeing. So there is a risk to it. But I do think it's really important. But the risk is if you over triage lots of patients thinking they're P1 plus, those true patients that are, and by that I mean the P1 plus patient being the patients that are going to die on scene in the next 20 minutes, 40 minutes, the patients with significant airway problems, the patients that have, non-compressible hemorrhage, that are actively bleeding to death, and that if they don't leave scene urgently, they will die on scene. These are the cohorts of patients we're talking about. And the patients that perhaps, those identifying them through things like the hateful eight, and kind of that they're kind of looking at their trajectory of how they're deteriorating perhaps over 5-10 minutes. That's the cohort of patient I mean.
I think just listening to you talk then, Keir, makes me think about those patients from Manchester that were within the cohort deemed to have potentially have had preventable deaths, either compressible hemorrhage that weren't compressed just due to medical equipment on scene, or time to definitive care, or those with uncompressible hemorrhage. And I think again, talking about the role of enhanced care teams, APPs, CCPs, doctors within. I desperately try not to get dragged into the zonings of major incidents, but to where the sick patients are, let's just say that, and be able to identify and treat them with that higher level of experience, knowledge, exposure, all those sorts of things. Used to working under stress. I think this is what hopefully 10 Second Triage will facilitate. The other standout strengths from it that I really like, it's probably a good time as well just to sort of recognise the authors, Claire Parks, Sean Harris. I think they've really taken the time to qualitatively extrapolate data from people that have been to these incidents to help them shape new triage tool. It's been a big piece of work, and I can speak of that. I can speak to that firsthand. But the other standout strengths of 10 Second Triage, I think, exactly as you said, Owen, I think in these really, really high stress situations, sort of to use the example that's perhaps more familiar with our practices, AVPs, CCPs, paediatric arrests, we tend to try to double up jobs. So when it comes to drug administration, checking the correct dose and then administering it, in an ideal world, we would try to put two clinicians together to do that one task, because we know that it's stressful. It's 5 o'clock in the morning. It's highly emotive. These are the times where we can either make errors or find ourselves under a lot of stress. So it's a really nice way to mitigate that, is to double up these roles. And we said it before, we're lucky in London that you press a button and typically we're quite quickly well resourced for these types of jobs. But I do think that is my experience from working out in the counties, and it's only very recently, is that actually, these are the resourcing situation. It can be replicated. Like I've done jobs recently where there's been, if anything, it's been over these big multi-patient RTCs, if anything, have been over-resourced. So, and the other nice thing about 10 Second Triage is that, exactly as you alluded to, Owen, you can split with other emergency responders, and hopefully it will enable our colleagues from the emergency services who typically have probably really wanted to help but not known exactly how they can. We can now form these small flash teams of a police officer and a firefighter, or a police officer and an ECA, and they can go around and triage and be that much more effective as a two, hopefully mitigating slightly more effectively mitigating the stress, and be that more effective as a team. Whereas typically this sort and sieve would be done by 2 ambulance service clinicians, which isn't the optimal way to manage your resources.
So it's probably worth just reiterating them, really. It's about the kind of co-location, communicating, coordinating, having a joint understanding of risk, and sharing your situational awareness either through methane or the joint decision model. And the idea really around JESSIP is to ensure that emergency responders are trained and exercised to work together as effectively as possible. And that should be at all the kind of levels of command in response to kind of major or complex incidents. But I think it's really important to think that I think some people, if you're kind of like, kind of new into the job, you might just be thinking this applies to scene commanders, but actually I think it applies to everybody. And I think we keep talking about arriving into jobs early in that first 20 minutes, that if you arrive into scene and you're one of the first few resources, and some police officers also arrive, who might be from like one of the borough response teams, or actually using those JESSIP principles early with those first arriving police officers or first 5 responding firefighters is really important, because it starts to build up a kind of foundation to how that incident is going to progress. Because if you're working together and you say to those police officers, because it's very easy for you to go off and do ambulancey things, for the police to go off and do policey things, but actually you've lost situational awareness of what everybody's doing. Because if you then come together and you say, right, guys, listen, what we're going to do, we're going to walk this scene together, because we need to gain situational awareness. We need to understand the risk. And then if you declare a major incident early, the police are fully aware of that, and they can then let their control room know. And likewise, if they do the same. And I think kind of interoperability is defined as the extent to which organisations can work together coherently as a matter of routine. And I think routine in that statement is the key word. And it's what you do day in, day out in your routine practice that either sets you up to fail or succeed. So it's kind of like, although it's building the relationships on scene, those relationships between different organisations, different teams, different clinicians, it happens in the days, months and years before you find yourself at that major or significant or complex incident. Because when you start to build up cooperation with people, you train together, you exercise together, you go along and give talks at their clinical governance days or their training days, you start to build up those relationships with people. So you start to get an idea of what their skill sets are, what their capabilities are, how different teams can be utilized in incidences, and what their expertise is, and how are they best going to fit into that scene. And I mean, you saw it, in the City room at Manchester. It was an APP and 2 heart paramedics were working together. Well, have they worked together before? Did they know each other? How was that interaction with one another? And we've been really lucky, and I have to give a shout out really to the EPRR and LAS Heart. Over the last 2 years, we've been invited up to go and train alongside them at Lincoln in the urban search and rescue. And that's not really around training APPs to go into kind of collapsed building structures, but it's about actually kind of 2 different teams going to learn about what each other is capable of doing. It's about breaking down boundaries. It's getting to know each other. It's building trust. It's kind of that when you undertaking that sort of training together, and then going in the evening to have a drink with each other, have dinner with each other, you're forging relationships. And at some point in the future, we know as APPs, as HEMS teams, we will probably be working alongside those teams at some point in the future at a major or challenging or significant incident. So if that's the first time you've met each other, if that's the first time that you've worked alongside each other, you're not going to be as maybe as slick as you would be. There might be misunderstandings about decision making, or why decisions are being made, or something that needs to be done. And when you know each other and the relationships have been kind of built and barriers broken down, your communication is far stronger. You're not worried about having that kind of there being a breakdown in communication, or you have a better understanding. And I think ultimately, and I think what Alex said is, you need to know the people you work alongside. And that doesn't need to necessarily be around knowing them personally, but it needs to be about their culture, the team culture, the organization they work in, what they're capable of delivering as clinicians or as a team, that when you all find yourself in this situation, you can gel. Because ultimately, readiness without training is not going to kind of result in good results. And it leads to kind of hesitancy, underconfidence, and lack of awareness.
Scholars and historians have looked at how Nelson managed to defeat Napoleon, and they it's exactly what Keir's talking about. They've coined this term, the Nelson's touch, and basically it was all about Nelson was pioneering in that he moved away from a very traditional, didactic, hierarchical way of working with his subordinates or his officers or his crews, and in fact more akin to sort of Henry V and Shakespeare. He would have dinner with them. He would see them as his equal. We talk a lot about flattening hierarchies and things like this. This is effectively what Nelson did, and ultimately it created trust. And I think that's what Keir's, what I've got from what Keir said. I think it's about creating trust, having simple strategies rather than complicated plans, and the knowledge that you'll have these almost siloed little things that are going on, that everyone's working together under their own initiative. And maybe that's a nice sort of summary of what we've all been talking about, and how, me turning up, trying to support colleagues and scene, empowering people. Not that for a second I'm likening myself to Nelson, but I think it's all something that we can aspire to be like. I think we often talk about this flattening hierarchies and all this sort of stuff, and actually what we're trying to get to is exactly that, which is creating trust.
Fundamentally, I think it's to be prepared for these events as they come on run-of-the-mill shifts. I think for a successful response to a major or challenging or significant incident, It's about how the organisation, the team, and the individual responds to it, because each influences each other, and without one, the others couldn't function. And I think this is really determined by the underlying culture that is developed within all of those kind of three things. And but what I mean to that is it's around seeking clinical excellence and around clinical care and scene management. And it's mastering the basics of those things. And it's then kind of reflecting on past experiences or what you have then kind of practiced and kind of debriefing it, taking out the key learning lessons and then implementing those lessons into your system. And because getting the basics right is really the foundations to high performance. Then kind of, for individuals or teams, it's implementing things like Alec really kind of touched on this in the last podcast, is around implementing kind of major incident practice into your daily working routine. And that's by what I mean by that is by like using EFAME, using the Jessup principles on kind of smaller interagency jobs. It's knowing your kit, it's knowing your triage packs, it's building mental models about what you're going to do within that first 20 minutes should you find yourself on the scene. Where are you going to park? Where are your cards? How are you going to report? What is your plan as a crew? And I think that's really important. I think many of the lessons that have been identified, certainly around in Manchester and other inquests, have happened in the past. And in 2013, the Pollock report was published, and it was commissioned to identify reoccurring failures of interoperability in the UK within the emergency services from past incidents. And the report identified the kind of common causes of failure, and that was inadequate training, ineffective communication, no systems to ensure that lessons were learned and staff taught those lessons, and that previous lessons or reports were not being acted upon. So for me, this really highlights that if organisations don't provide appropriate training to staff, that they communicate poorly or we communicate poorly on scene, and that we haven't learned from past incidents, that we're highly likely to repeat past failings when we're in the future, when we come to those scenes. And I suppose my final comment then is by Lord Taylor from the Hillsborough Stadium Disaster Inquiry. And he said it is a depressing and chastening fact that mine is the 9th official report covering crowd safety and control of football grounds. That it was allowed to happen despite all the accumulated wisdom of so many previous reports and guidelines must indicate that the lessons of past disasters and the recommendations following them had not been taken sufficiently to heart. There is no point in holding inquiries or publishing guidance unless the recommendations are followed diligently. That must be the first lesson.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.